Acute liver failure is a devastating multi-organ syndrome characterized by sudden and severe hepatocellular dysfunction in the form of jaundice, coagulopathy and encephalopathy, which develops in previously healthy individuals. Mortality ranges from 30 to a massive 100%. It has been defined differently by the eminent scientists and institutions, differently depending on the duration of symptom onset. Trey and Davidson defined it on the onset of hepatic encephalopathy within 8 weeks of the first symptom of illness in patients without pre-existing liver disease. O'Grady et al. Classified it into 3 stages: hyperacute less than 7 days, acute ranges from 8 to 28 days, and subacute when the first symptom developed 28 days to 6 months. The International Association of Study of Liver divided into 2 categories: acute liver failure that developed, in which the fulminant hepatic failure developed within 4 weeks of the first symptom onset, and subacute liver failure developing in between 4 weeks to 6 months after the onset of symptoms. It has currently been described as illness of less than 26 weeks duration with coagulopathy in the form of INR more than equal to 1.5 with any degree of hepatic encephalopathy in patients without any pre-existing liver disease or cirrhosis. Exceptions to this are Wilson's disease, vertically acquired hepatitis B virus infection, autoimmune hepatitis, or hepatitis D virus superinfection in patients with chronic HBV infection. It has a varied etiology ranging from viral, drugs, toxins, metabolic or genetic syndromes, neoplasms, pregnancy-related complications, vascular syndromes, and many more miscellaneous and indeterminate causes. Viral hepatitis remains the commonest cause worldwide. Drug-induced acute liver failure, particularly due to acetaminophen, predominates in the US and many parts of Europe. Indeterminate ALF attributes to 20% of fulminant liver failure cases. Viral hepatitis. Less than 5% viral hepatitis infections cause acute liver failure. Out of these, hepatitis A cases attribute to 0.2 to 0.4% of cases, and that too mainly more than 40 years of age. Hepatitis B, 0.1 to 1.2% cases land up in fulminant liver failure. More prone to this are the female population and the Asian and Eastern European population. Diagnosis is made based on the IgM anti-HBC levels. HbS-Ag is negative in 55% cases of HBV acute liver failure. Rapid clearance is a favorable outcome. Also, better outcome following liver transplantation is there. Hepatitis C rarely leads to fulminant hepatic failure, though co-infection or superinfection with HBV leads to fulminant hepatic failure. Hepatitis D, superinfection with HBV ALF is seen in up to 40% of cases. HSV 1, 2, 6, varicella zoster virus, cytomegalovirus, Epstein-Barr virus, parvovirus B19, HSV 6, yellow fever virus are other viral infections leading to fulminant hepatic failure. Then drug and toxin-induced liver injury. It is in the form of intrinsic or direct hepatotoxins or idiosyncratic hepatotoxicity. In intrinsic hepatotoxins, they are predictable and reproduce causing a dose-dependent hepatocellular necrosis with a brief period between exposure to the drug and development of liver toxicity. That is, the latent period is defined in intrinsic or direct hepatotoxins, whereas it is unpredictable and there is no latent period described in idiosyncratic hepatotoxicity. Acetaminophen is the most common offender. Out of these, 45 to 50% of all ALF cases being caused by the drug-induced liver injury, followed by herbal products that account for 11 to 15%. Then acetaminophen, 2% of acetaminophen is excreted via urine, and rest more than 90% is conjugated. Its toxicity is dose dependent, and the dose for that is 7 to 10 grams per day in adults or 150 mg per kg in the children. The course of its disease starts as, in stage 1 we see few signs and symptoms which develop within 24 hours. In stage 2 there is development of clinical and lab evidences of the toxicity which occurs in another 24 to 72 hours, and then in stage 3 finally there is overt hepatic encephalopathy, coagulopathy, hyperbilirubinemia, renal dysfunction and lactic acidosis. Mortality goes up to 30%. There is best spontaneous survival rate seen in 68% cases, and lowest seen in liver transplant cases, that is 6%. Then mushroom poisoning. Scientific name of mushroom is Amanita phalloides. There are two heat stable toxins produced by mushroom. One is phallotoxin, which causes damage to enterocyte membrane, then alpha amanitin, which causes a dose dependent damage to cell mRNA. The lethal dose is 0.1 to 0.3 mg per kg. The course of its toxicity ranges from within 12 to 24 hours there is GI intolerance in the form of diarrhea, vomiting and abdominal pain. Another 24 to 48 hours there is hepatotoxic phase. Then 4 to 7 days it leads to acute liver failure, hepatorenal syndrome, hemorrhage, convulsions, coma and finally death. Mortality approaches between 10 to 30%. Then there are idiosyncratic hepatotoxins. Up to 20% of all ALF cases are due to idiosyncratic hepatotoxins. These reactions occur in two forms. One is hypersensitivity, that is immune mediated type, and the other is metabolic idiosyncratic reactions. Hypersensitivity reaction in the form of rash, fever, eosinophilic leukocytosis, eosinophilic or granulomatous hepatic inflammation with hepatocyte necrosis and cholestasis is seen mainly with phenytoin, amoxicillin, clavulanate, erythromycin, sulfonamides, halothane, dapsone, diclofenac, carbamazepine and sulindac. Metabolic idiosyncratic reactions seen with isoniazid, ketoconazole, disulfiram, valproate, troglitazone and amiodarone. Then there is pregnancy associated acute liver failure. It is mainly seen in patients having acute fatty liver of pregnancy and the HELP syndrome during the third trimester of pregnancy. Acute fatty liver of pregnancy, the incidence is 1 case per 7,000 to 20,000 deliveries, mostly seen in young population from 16 to 39 years of age, the primary gravida and having hallmarks of preeclampsia, that is hypertension and proteinuria. They also have defective long chain 3-hydroxyacyl coenzyme A dehydrogenase. In these patients, serum aminotransferases go up to 1000 international units per liter and hyperbilirubinemia averaging around 15 mg per deciliter. Histology shows centrilobular and mid-zonal hepatocytes swollen with microvesicular fat globules. HELP syndrome. In patients with HELP syndrome, we see preeclampsia signs in 85%. In these, as opposed to the AFLP, the serum aminotransferases and LDH are less than 500 international units per liter. Histology shows massive hepatic necrosis, marked steatosis and necrotic vessels with intravascular thrombi. Then autoimmune hepatitis, its presentation is acute in only 25% cases. It is a diagnosis of exclusion since there are no classic signs. At times serum antibodies may also be absent. In that case, liver biopsy is helpful for diagnosis. Less than 5% of Wilson's disease land up in acute liver failure. It is marked by low serum alkaline phosphatase levels along with an alkaline phosphatase to total bilirubin ratio of less than 2 or an AST to ALT ratio of more than 2 to 3. Cardiovascular diseases lead to hypoxic hepatopathy, shock liver in 1% cases. Aminotransferases here are over 10,000 international units per liter followed by rapid resolution. Few severe vascular obstructions like Budd-Chiari syndrome, sinusoidal obstruction syndrome due to medications or herbs and malignancies, they also involve the liver and lead to fulminant hepatic failure. The diagnosis is made regardless of etiology. If there is altered mental status, that is hepatic encephalopathy plus jaundice plus elevated aminotransferases and elevated prothrombin time within 26 weeks of first symptom onset in a patient having no prior liver disease. For diagnosis, some general tests, some basic tests are done to look for electrolyte imbalance in the body, including sodium, potassium, chloride, bicarbonate, calcium, magnesium, phosphate, glucose levels, then renal function like creatinine, blood urea, nitrogen are calculated. Then hepatic panel includes the aminotransferases, alkaline phosphatase, total bilirubin and albumin. For coagulopathy, we need INR or prothrombin time. Then complete blood count to look for white blood cells, hemoglobin, hematocrit and platelets. Then we need arterial blood gases, blood lactate level. For specific etiologies, we need to screen for hepatitis A, B and E viruses. For acetaminophen toxicity, we look for drug levels in the blood. Autoimmune hepatitis is ruled out by autoantibodies in the serum. For idiosyncratic drug reactions, we see eosinophil count and liver histology. For acute liver, fatty liver of pregnancy, ultrasound, serum uric acid levels and liver histology are helpful. In HELP syndrome, we need aminotransferases and platelet count. For preeclampsia and eclampsia, we need hypertension and proteinuria. For Wilson's disease, urinary copper, serum ceruloplasmin levels, serum alkaline phosphatase, bilirubin ratio, serum AST on ALT ratio, slit lamp examination for KF rings. For Budd-Chiari syndrome, imaging of hepatic veins is needed. Hepatic malignancy is ruled out by liver histology and imaging of liver. Ischemic hepatitis, for ischemic hepatitis, we need aminotransferase levels. Then clinical course and management of acute liver failure. Cause of death is mostly cerebral edema with herniation and infection or sepsis. Supportive measures that can be done are patient needs to be hospitalized in case of altered mental status and or coagulopathy in the form of prolonged PT to 4 to 5 seconds and INR more than equal to 1.5. Patient needs specialized unit if INR is more than 2 or grade 2 or higher encephalopathy is there. How do hepatic encephalopathy and cerebral edema develop? The mechanism for this is ammonia rises and leads to renal failure and impaired skeletal muscle function. Then there are central pathways, that is glutaminergic, serotonergic, non-adrenergic, activation of GABA receptors and production of false neurotransmitters. There is disruption of the blood-brain barrier, loss of cerebral autoregulation. Then SIRS, systemic inflammatory response syndrome, that is weakened blood-brain barrier allowing an influx of inflammatory cytokines. Then subclinical epileptiform activity due to excessive central nervous system glutamate. Lactulose can be given to the patient, but it never been shown to improve overall survival in acute liver failure. It prolongs survival, could be used in the setting of just grade 1 and 2 HE. There is always risk of aspiration as the patient becomes more encephalopathic. Therefore, oral lactulose should not be used in these patients unless they are intubated. The non-observable antibiotics like rifaximin, neomycin have not been tested in this setting. The head end of the bed should be raised to 30 degrees. Mechanical ventilation with sedation should be used. Then hemodynamic abnormalities develop due to splanchnic vasodilatation, low systemic and pulmonary vascular resistance, elevated cardiac output, increased metabolic rate and systemic hypotension. Hypovolemia should be corrected. Vasopressors in the setting of normal intravascular volume should be used. Norepinephrine is often the recommended vasopressor, although dopamine may have a more beneficial effect on peripheral oxygen delivery, side effect being cerebral hyperemia. Terlipressin has conflicting results. Corticosteroid insufficiency may contribute to hypotension. Coagulopathy and thrombocytopenia due to decreased hepatic synthesis of both procoagulant and anticoagulant factors and low-grade disseminated intravascular coagulation. PTINR is decreased due to decreased hepatic synthesis of factors 2, 5, 7 and 10. Lack of improvement in the INR after vitamin K replenishment shows decreased hepatic reserve. Fresh frozen plasma should be used only for active bleeding or when needed to perform invasive procedures. No prophylactic use is seen, in fact leads to volume overload. Reduce procoagulant factors like protein C, protein S and antithrombin 3 and increase factor 8. Hypofibrinogenemia, if it is less than, fibrinogen is less than 100, we should give cryoprecipitate. Platelet count declines progressively and less than 1 lakh in 70% of ALF cases. Renal failure. For management of pregnancy related acute liver failure, delivery should be attempted as soon as reasonably possible. Fetal death occurs in 42 to 49% with only minimal improvement with early delivery. HELP syndrome may be complicated by hepatic infarction or hepatic rupture. Autoimmune hepatitis, there is no role of corticosteroids or immunosuppressant therapy. In Wilson's disease, plasmapheresis may help to bridge the patient to orthotropic liver therapy, transplant. Then for non-specific therapies, drug-induced liver injury, currently there is no standard therapy. N-acetylcysteine shows significant improvement in transplant-free survival in patients with early stage encephalopathy. Hypothermia may be helpful up to 33 to 35 degrees. It decreases the likelihood of cerebral edema. Then Prometheus, this is a membrane that is permeable to albumin and albumin bound proteins. Therefore, the secondary circuit utilizes the patient's own albumin for detoxification, but there is greater risk of clotting. Then liver transplant, survival rate benefit from 20% increased to 60%. Whole organ deceased donor liver transplantation. Then living donor renal transplant, there are few complications with living donor renal transplant as biliary complications, small for size syndrome, graft of less than 40%, weight is at risk for development of portal hypertension. Auxiliary liver transplant, in this recipient's liver in place using a partial left or right lobe from the donor, which acts as temporary support for the recipient's injured liver. Then prognosis and prognostic model, 37% will recover spontaneously without the need for orthotrophic liver transplant, 20% may be transplanted needlessly. Degree of serum aminotransferase elevation and the rate of its recovery do not predict prognosis. Then hepatic encephalopathy, those with more rapid development of hepatic encephalopathy, that is acetaminophen induced, appear to have a better outcome compared with those with a longer interval between the development of symptoms and encephalopathy. Thank you.